who don't know me, my name is Chintan Pancholi-Parekh. I'm a physical therapist originally from New Jersey. My business partner, Marissa Muccio, her and I have had a practice in New Jersey, then expanded into South Carolina. And for a few years, we were also in New York and Austin, Texas, but currently our practices are in New Jersey and South Carolina. We both have been physical therapists for a long time. We won't date ourselves, but our passion for scoliosis kind of started approximately 15 to 16 years ago. Marissa has a great story. We'll save that for later on how we kind of stumbled upon scoliosis world, but we've been doing it. We were the first ones in New Jersey to start scoliosis specific exercises. And we have expanded into not just practicing scoliosis specific exercises, but educating it, spreading the awareness, whether it's via educating doctoral students, other healthcare professionals, or even meeting with doctors and doing some research. So when we talk about depth and breadth of getting into scoliosis, Marissa and I are 2 feet forward. Today, we also have Nikos joining us. I will give a long-winded presentation on all of his qualifications in a little bit, but basically he is the one who developed the PSSE-Schroth method. This is our tentative agenda for today. We're just going to go review some of the conservative treatment of scoliosis, kind of like history of the Schroth method before we go into what really is PSSE-Schroth method. All right. So here's just some information if you guys wanted to contact Marissa and I personally. Here's feel free to take a screenshot. We'll put it up later too. So wait, before we do go into this, what do you guys know about scoliosis? Nikos, can we try to do our little poll? We have a poll, guys. Let's see if this works. You guys, everybody see the poll?
Yeah, we already see some of the answers. So it will be good to have a first impression of our audience.
Nikos, you see all the answers coming in?
Yeah, I don't know if it is visible to the other or not, or just to me.
Yeah, just to you, I think.
All right, okay. So what we have so far is almost 50% they are working with scoliosis, having some experience, but they are not certified. Then we have 35% they work and they are certified in a PSSE school, and 15% they don't work with scoliosis. So we have a mixed audience, but most of them, they have already some experience, more or less.
That's amazing. So I won't bore most of you, but the ones that want to learn more about it, definitely, I want to kind of go back to what is the history of scoliosis, right? It's been around a long time. If you are anywhere in the physical therapy world, we know so many of our patients, no matter what setting we are in, you are going to get exposed to scoliosis. Well, it is a very, very, old diagnosis. It comes from the Greek word crooked. And as far as how it has been documented in history, some of the Hindu scriptures also talk about how one of the deities actually corrected scoliosis by doing elongation, which is one of the principles is in still use. What is the actual definition of scoliosis? Obviously, there is an obliquity and side bending. And if you look at some of the medical literature, they do talk about the curving of the spine. And with the invention of x-rays, probably more focus has been on the coronal plane. However, with SOSORT, we'll go over what SOSORT is. It is a conservative society. It's a medical society that really focuses on conservative treatment. It is a a society that has physical therapists, orthotists, as well as physicians, PhD, a wide variety of professionals who come together in one singular focus, which is to advance the treatment of scoliosis. Well, their definition is that it's a three-dimensional torsional deformity. So there is definitely a side bending. There is a axial rotation, as well as a change in the sagittal plane. So there could be changes in the kyphosis or the lordosis of the spine. Not always, but it is present. And if any of us remember from school, we were kind of taught functional scoliosis, structural scoliosis. That really was the extent of the type of scoliosis education I got. Functional was something that was caused by non-structural issues, poor posture, leg length. And usually if you correct that, it would be addressed. Structural was definitely more of something in the spine is changing. And by definition, it would be something with a Cobb angle of 10 degrees. There are different types of structural scoliosis. And again, I don't want to spend too much time in here because I know a lot of you guys are very experienced in it. But a majority of when I first started in the PSSE world was absolutely focused on the adolescent idiopathic scoliosis. Now, the use of the PSSE is getting expanded. So I think there is no reason why we leave the neuromuscular cases off, and also a lot of advancement in the degenerative scoliosis. So how does scoliosis get detected and diagnosed? A lot of you guys remember this from high school. If you are from the US, the nurse or the gym teacher took you in the gym, had to take the shirt off and had to do bending. I know my heart always raced when I had to do that and be like, oh my God, what if they find something? While they were doing an Adams forward bend test. And with people who are a little bit more savvy, they will use something called the scoliometer to detect it. And other things that you can look at to kind of screen for scoliosis is looking at some of the postural deviations. As a physical therapist, you might use a plumb line. You might use a postural grid to look at some of the deviation. Is there a waist window changes? Is there shoulder height differences? Is there the scapula not sitting correctly on one side compared to the other? The most important thing to know is that once you find that there's at least 5 degrees or more deviation on that scoliometer, it is kind of enough to send it out to the doctor, because the gold standard is an X-ray. We want to make sure that to get diagnosed for scoliosis, it has to be an X-ray and it has to be 10 degrees or more, at least according to the medical society. Well, what do we do about it? And as most of you know, there are things that we can do now. However, a lot of the previous studies before the more recent kind of, I would say, the influx of PSSE, at least in the United States, we basically took physical therapy out of the equation because there were plenty of studies that showed really no impact on scoliosis. It really didn't make a difference. They use things like, these are just some studies that I want to throw out there, talking about electric stimulation, or talking about just general exercises, making no difference in the curve. So what have we learned? Definitely since, like I said, having the PSSE come here in the last decade and a half, there have been plenty of studies, and we can definitely go over those. But we know that is the reason why PT in the beginning didn't work, because we were solely focused on the single plane. We were thinking about that X-ray and about the side bending. And I know in my school, I had one slide, stretch over the ball or do core exercises. Those were the only thing that were given to me as what I could do as a physical therapist. Wow, times have changed, definitely. With this little yellow book, which started it all, many of you, I know I've tried reading it, and it is completely different than what has been in practice, at least even since I started practicing 15 years ago. Krista Leonard-Schroth and her mom, Katerina Schroth, both are the pioneers in the Schroth method. However, now, if you look at all of these, there's so many other physical therapy or physiotherapeutic scoliosis-specific exercises out there. And this is an excellent slide from our colleague, Eric Perrant in Canada. And he kind of shows all of the areas of scoliosis that can be impacted. And you can see Schroth across the board does affect it in multiple ways. However, I feel like, at least me personally, who has been certified in the Schroth and the CIAS and the different versions of the Schroth, I say it is so blended now, and how using different techniques and creating a blend has made me a better physical therapist. And as you can see, other medical societies are also really supporting this new wave of treating scoliosis. So why do you think PSSE-Schroth is the right answer? Like I said, the blend. I think in that way, I feel like I have to really introduce Nikos. He is basically the founder of the PSSE-Schroth method. He has been a physical therapist for many years. He was certified in the Barcelona method, in the ISST method, in the Schroth best practice method. He also became certified in the CIAS method and the Leon method. And he also taught for the Barcelona school. And he gave over 400 courses. He was in the thick of it when he realized that I need to do something more. There's something missing. I need to create something. That's when he opened up this school and created a curriculum that was so unique. I think it helps clinician make that decision and treatment so much easier. The things that I played with when I was a new therapist, I think this particular method really answers a lot of those questions. So without further ado, I don't want to take up too much time. I want to actually introduce Nikos, and I'm going to let him explain the beauty behind his school.
Thanks for this nice introduction, Chintan. Hello to everyone. And let me share my screen with you. Okay, I think I'm not going to spend a lot of time in this slide because most of them they've already explained to you by Chintan. These were the schools that I was educated, and I'm really grateful for having these wonderful teachers from all these schools. So by getting my own knowledge and my own clinical experience, I try to develop some new concepts, and this is exactly how you will see the PSSE-Schroth method that was developed 2.5 years ago. So what we are is a program of physiotherapeutic scoliosis-specific exercises working both for scoliosis and kyphosis treatment. And our concepts are acquired by clinical experience. We are definitely based on the original Schroth principles as they were described by Krista and Katerina Schroth in the past. We got some adaptations from other PSSE schools. And the main idea behind PSSE-Schroth was to keep the advantages of the education that I already got and try to improve what was a limitation, or trying to fill in the gaps that were created. And we also developed a new care type classification and some innovative ideas for 3D correction. So in terms of practical application, the advancements that we apply in our school is, first of all, the basic idea is to try to treat our patients precisely and safely, getting the maximum effect of the exercises based on their care type. So some innovative concepts of tree corrections can be found in our school. New terminology, improving the accuracy of describing the body blocks and the concepts of correction, new ideas for corrective breathing, new techniques for muscle activation. You will see, some of you that you are familiar with the term shoulder counter traction. We also have the thoracic counter traction on the L side, new concepts for ADL training, based on our classification and the introduction of the selective overcorrection. I will explain this a little bit later in more details. New exercises or a different execution of already existing exercises, mobilizations. We combine a lot of corrective breathing with specific mobilizations during exhalation, and we pay special attention to proximal thoracic scoliosis. So when we have the apex being from T5 and above in the upper thoracic region. Also, special attention to thoracolumbar curves that are a little bit complicated, and large variety of exercises for kyphosis and scoliosis. And going to our classification, the main idea behind that was to keep the classification easy and accurate, describing all curve types, and the therapist can go into any curve type in our classification just by answering 3 simple questions to themselves. You will see the questions in a while, and to our perception, the classification is not just to divide the curves into different categories, but the classification should give to the therapist the proper information on how to accordingly treat our patients later on. The concept of overcorrection, again, is going to be described in a while in more details. It means that we're not the first school that will overcorrect, of course, but the decision if we overcorrect or not overcorrect is taken from our initial classification based on some criteria that will be analyzed on the next slides. Clinical, radiological, and prognostic criteria should be used by the therapist. And the main concept is to get the maximum correction for the curve types when this is recommended, but avoid creating compensations when it is going to be risky, like when you have double and balanced scoliosis. And with this classification, I hope that we try to put the therapist outside of difficult decisions, at least as much as possible. So this is a Greek word, dilemma. I like to use it quite a lot. Dilemma means you are in a borderline situation and you don't know which one to decide. So many times you are in a difficult situation when you want to classify and treat curve types that are balanced. So when you have thoracic and lumbar to be both of them significant or to be both of them mild, and you have to decide from the beginning if the thoracic is the major or the lumbar is the major, that's a big dilemma sometimes for the therapist. Also, how to classify and treat curve types when the pelvis is almost balanced. Those that you are more familiar with the BSPTS techniques, that is a main decision to be taken. I'm sure that you have seen some patients that you cannot decide if the pelvis is balanced or slightly imbalanced, and this is a difficult decision. Or how to classify and treat curve types when you don't know if thoracic is structural or not, or the thoracolumbar curve with the apex T12L1, because thoracolumbar are quite special types that include some part of the thoracic and some part of the lumbar region, and sometimes they behave more like thoracic, some other times they behave more like lumbar. So the therapist many times can be in these difficult decisions, and we hope that by our work in this classification, we try to take you out of this difficult position. Now, these are the 3 simple questions that should be answered by the therapist to go into the classification. So the first question is, do you have a structural thoracic scoliosis? That's very easy to be detected. You can do the clinical assessment first with the forward bending test, and you can see if there is a hump on the thoracic region. Then, of course, you have to go to the X-ray to confirm your clinical diagnosis. The second question is, where is the position of the pelvis in relation to the trunk? And I have to pinpoint that we speak only about the frontal plane position. So the pelvis can be on the left, on the right, or in the middle. We don't speak about, for the classification at this point, we don't speak about the rotation or the tilt of the pelvis. Obviously, we take care about this later on when we treat our patients, because we need to put everything in the ideal alignment. But for the second question, the answer is, where is the pelvis in the frontal plane? And the third question, I think this is the main addition from our classification, is overcorrection allowed for the main curve? And I know that maybe the first two questions, you can even get a decision by a clinical assessment. You can see if there is a structural curve or where is the pelvis. But for the third question, I know that maybe now you're wondering, okay, then what is this kind of overcorrection and what is the main curve? Because I just presented to you 2 slides ago that sometimes it's really hard to decide which is the main curve, but you will see how we give the answer to you. Now, speaking about the exercises and the decision for overcorrecting or not. Here I have to clarify something, that in our school we have two different types of exercises. We have the normal exercises, and these are the vast majority of the exercises that we give to our patients, that we try to reach the perfect 3D balance for them. So no lateral flexion is allowed for the patient, because lateral flexion is always some overcorrection. By lateral flexion, you correct more one part of the body with a compensation to another one. So these are the majority of our exercises. And we also have the overcorrective exercises like the one that you see here. And in the overcorrective exercises, there is one and only purpose: to get the maximum of correction for the main curve. So in these exercises, we know that we will create some compensations because we allow lateral flexion, but we will create the compensation only during the exercise. You will see what is our concept later on. So here you can see a patient with a very significant thoracic scoliosis doing the mermaid on the floor exercise, and you can see the significant amount of overcorrection that you can get by this exercise. And we also have overcorrective techniques. So the overcorrective techniques, obviously they are applied in the overcorrective exercises, but we also apply the overcorrective techniques in some normal exercises, only in some specific curve types, okay? So when using the criteria that you will see on the next slide, and you finally decide that no overcorrection is allowed, of course, you know that you have these types, the minus, you will see later on, we'll analyze all of them, and you are not allowed to do any overcorrection in any exercise. That's very clear. But when your final decision for the third question is, yes, we can overcorrect, then you have to decide as a therapist how much overcorrection is needed for you. And this is what we call as selective overcorrection. So in plus curve types, when you answered, yes, we can overcorrect the main curve, the therapist can decide how much overcorrection is needed based again on some criteria. But for one more time, as you will see in a while, we don't leave the decision fully to you because we guide you. There are some plus curve types that you only have to do selective overcorrection, because if you overdo this, then you will have problems. So the idea from our school is not regarding the lateral flexion, for example. There are some other schools that they say no lateral flexion in any exercise. It's not allowed. It's clear. This is their own philosophy. No doubt. There are some other schools saying in every exercise you do lateral flexion for the main curve to get the maximum of correction. So we are somewhere in between, saying it's not only black and white. It's not only you overcorrect or you never overcorrect. You can do it selectively, and if you do it selectively, what you can get is the maximum of correction without creating any compensation. So that's the main idea behind the overcorrection for us. Now, let's have a look on the criteria that you have to use. I know this slide looks quite complicated, so you see many different criteria, but the way we educate our therapists is to give them very good knowledge about clinical, radiological, prognostic assessment. And this is actually something that we always have to do as therapists, because even if the patient is referred to our clinic by the doctor, then we still need to decide which criteria to use to take a decision about the intensity, the treatment plan, duration, and so on. So the clinical criteria: trunk rotation, frontal plane asymmetry, pelvic tilt can play a role between these two types, significance of structural curves and rigidity, radiological criteria, comb angle, rotation of the vertebra, deformity of the vertebra, growth stage, significance of structural curves, again, frontal plane asymmetry and in-brace correction, and prognostic criteria, risk for progression, short-term, long-term, pain, cosmetic issue. All these factors should be taken into account altogether. You make an analysis, a synthesis, and you go to your clinical decision. Now, this is the full classification. I try to explain because this slide looks to be very busy, but I will do this for you in a way that I hope it can help you to understand much better. So we have the K type is only for kyphosis. So thoracic kyphosis, thoracolumbar, and lumbar only sagittal plane deformity. Now, remember the three questions that you have to answer. The first question is, do we have a structural thoracic scoliosis? If your answer is yes, you go to the second question. The second question is, where is the position of the pelvis? And here you have only three answers. The pelvis can be either on the thoracic concavity or the convexity or in the middle. So when you have a structural thoracic scoliosis with the pelvis shifted to the thoracic concavity, this is the 3C type for us. When you have a structural thoracic scoliosis with the pelvis shifted to the thoracic convexity, as you see here, our classification is 4C. When you have structural thoracic scoliosis with the pelvis balanced, this is non-3, non-4 type for us. And when you don't have a structural thoracic scoliosis, but you have a lumbar or thoracolumbar, this is SL-STL, single lumbar or single thoracolumbar. I'm sure that those that you are already certified in BSPTS, to that point, you are very familiar. So the main advancement from our school is the next question. If we can overcorrect the main curve using the criteria that you saw before, so if you say, yes, we can overcorrect, we have the plus types, 3C plus, 4C plus, non-3, non-4 plus, SL-STL plus. If based on the previous criteria you decide no overcorrection, then you have the minus types. So in total, we have 8 different types in our classification, and we also have the S type, which means if we have a structural proximal thoracic scoliosis, and the S type can go in any type. So you can have 3C plus S, or you can have 4C minus S, and so on. So I have to delete them. I hope that this was quite clear for you on how you have to decide about the classification. Here on the next slide, you can see all these 8 curve types that we have in our school in standing, bending, and with their X-rays. We'll have a better look on all of them in a while. Now, we have also developed an algorithm for our classification, and the algorithm is exactly the process that the therapist has to follow in their mind. So the first question, do you have a structural thoracic scoliosis? Obviously, 2 answers only are permitted. If you say yes, you go directly to the second question. Where is the position of the pelvis in relation to the trunk in the frontal plane? And here you have 3 answers. Pelvis on the thoracic concavity, 3C. Pelvis on the thoracic convexity, 4C. Pelvis symmetric, non-3, non-4. If your answer to the first question was no, we don't have a structural thoracic scoliosis, if you have a structural lumbar or thoracolumbar, then you are on SL-STL type. And this is exactly like BSPTS for those that you are already certified in this school. But now, the work is not finished yet, because as you noticed before, in every of these 4 curve types, we have the plus and the minus. So we have the option to overcorrect or not to overcorrect them. So the third question, is overcorrection allowed for the main curve? Here, to make your life easier, we give you the answer, which is the main curve. So if you have classified 3C or non-3, non-4, your main curve is always the thoracic. So the third question can actually convert it to, is overcorrection allowed for the thoracic? Or do I have any other structural curve, and how significant they are? For 4C and SL-STL, the main curve is always considered to be the lumbar or thoracolumbar. And then if the answer is yes, you have the plus types. If the answer is no, you have the minus types in our classification. And here you can see one by one the curve types. So I will be very brief to explain you, also using some of the criteria to understand why plus and why minus, okay? First question, do you have a structural thoracic scoliosis? Yes, we have. On the right side, the pelvis is shifted to the thoracic concavity, so we have 3C. Then the third question, can we overcorrect the main curve? The main is the thoracic. You have to see if we have a lumbar and how significant is the lumbar curve. As you can see in this patient, clinically, almost no rotation, no deviation of the spinous processes. You go to the X-ray, you measure 45 degrees thoracic, the lumbar is almost nothing, very, very mild rotation, no deformity. Of course, you can understand in terms of prognosis, this is 45 degrees research zero, surgical candidate, high potential for progression. Also in terms of aesthetics, you can also consider this for the patient. So you definitely have to go to the decision of plus, and you can do overcorrection for this patient. This is why she was classified as 3C plus. But here we have a different patient with other characteristics. We have a structural thoracic scoliosis on the right. The pelvis is shifted to the left. So the pelvis is on the thoracic concavity. This is 3C. And then when you go to the third question, you will see that if you analyze, if you can overcorrect the main curve, so the thoracic, here you have more or less balanced scoliosis because the thoracic is 32, the lumbar is 28, which means that they are very balanced. Also, the lumbar has significant rotation, deformity. You can also see the pelvis to be higher on the right side. And this is the only curve type that we have the pelvis shifted on one side, but raised up on the other side. And I have to say that this curve type is not well understood so far. And the reason that we classify minus means that the lumbar is significant. This is why we don't overcorrect. And we also have, for those that we are more familiar, a different description of the body blocks, but it's not time enough to be analyzed here. Now, going to this type, we have a structural thoracic scoliosis. The pelvis is on the thoracic convexity, so this is 4C type. And going to the third question, can we overcorrect the main curve, the thoracolumbar in this case? We have 45 degrees thoracolumbar, 25 thoracic, not significant rotation for the thoracic. So this is why we can overcorrect. But in this case, you cannot overcorrect because you see structural thoracic scoliosis, pelvis on the thoracic convexity, so 4C. But now you see a very significant thoracic curve. So not a good idea trying to overcorrect the lumbar in cost of worsening an already significant thoracic curve. The next case, non-3, non-4, plus we have structural thoracic scoliosis, the pelvis is balanced, so non-3, non-4. Can we overcorrect the main curve, the thoracic? Yes, in this case you can overcorrect because the pelvis is balanced, but the lumbar is not very significant. I have to say here that in 4C plus, non-3, non-4 plus, and SLSDL plus, we do only selective overcorrection. So we don't overcorrect in every exercise because this will, for example, in this case, bring the pelvis out of balance at the end of the day. We don't really want to do this. But in this case, that you have another non-3, non-4 type, the pelvis balance with the structural thoracic scoliosis, you cannot overcorrect because the lumbar is already very significant. And last, no structural thoracic, but structural lumbar or thoracolumbar. In this case, I know that most of you will probably think that this looks like thoracic, but it's not thoracic. The apex is T12, so this is thoracolumbar curve, going very high in the thoracic region. So in every SLSTL type, you can say that this is a single curve. So of course you can do overcorrection. This is why it's classified plus. But there is only one exception. When we have a single lumbar or thoracolumbar curve with a degenerative adult scoliosis, just don't overcorrect. So this is the minus type. Sorry, this is okay for the classification part, and I think now we can open up the discussion section. So please send your comments, your questions to the Q&A section, or you can even raise your hand and we can allow you to talk. This is also an option. I hope it works because we had this issue with the chat. I hope this option can still work for you guys. And feel free to ask any question, or feel free to disagree with what you listen to us. We like to have nice discussions. So let me check if we have any question on the chat. There is a question on the chat from Rim. If there is a threshold to consider the curvature as significant. Let me explain you, because the term significant might create some misinterpretation. I suppose that your question is coming for the third question to our classification, if you can overcorrect or not. I will give you some examples to understand me. If you have a scoliosis, a thoracic scoliosis, let's say of 40 degrees, and your classification is 3C, and the lumbar is just 20 or 25 degrees, and not significant rotation, not significant deformity, of course, you can decide to do overcorrection for this curve type. But there is no threshold to consider the curve as significant, because you might have, for example, a patient with 18 degrees of thoracic and 15 degrees of lumbar. So 15 is not a very significant curve by itself, but you always have to analyze if the secondary curve is significant compared to the main curve, not just significant or not significant in terms of the curve magnitude in general. So the idea, I hope you can understand my answer to this question.
Can I also jump in on that question, Nikos?
Yeah, sure.
Sometimes I think the concept of whether or not a curve is significant, you might originally be thinking about it in terms of Cobb angle size. But again, keep in mind that the Cobb angle is a coronal measurement. And it's actually quite, while it is the established gold standard measurement, it is not all-encompassing. So for example, when those of us who have already been established and practicing one or more schools, we know we've had those patients who do not biomechanically, neuromotor performance-wise, behave like their X-ray category. When we describe, say, for example, I can have two patients with the exact same category of X-rays. One might play violin for a large number of hours. A lot of their neuromotor performance compensations biomechanically are in the upper segments. I can have that exact same curve in a child or a teenager who plays soccer on a competitive sport. And the majority of their neuromuscular motor performance compensation patterns might be lumbar and lower. So for that gray area, the beauty of what those of us who have been practicing for a while is that we've organically started to kind of see these variations. And this method of clinical rationale and the algorithm gives us a much more concrete decision tree to follow and to ask ourselves these questions. And for some, you might start with, it gives that flexibility, that space for, we might begin with this classification, but as we're executing it, I really see the motor performance is really, this curve is more significant from a neuromotor. It gives us that capacity to sit a little more comfortably in that gray selective area.
Thank you for this comment.
There is a great question. If you don't mind, Pablo, I'm going to field your question. This is an excellent question. Why do we care about maximizing overcorrection? For those that are in scoliosis and for those that are not, let me just introduce you to something about the physiology of idiopathic scoliosis when it comes to how it's growing and progressing. What we've become recent in the literature is we're understanding more and more about the disease process itself and something called growth modulation, right? When we think back to the Hutter-Volkmann laws, where the compression or forced distractions redirect the growth of the soft tissue structures as well as the bony structures, this growth modulation principle is being applied operatively for those that are familiar with vertebral body tethering for the last 15 years as well. We now have the literature that are demonstrating growth modulation in non-operative and bracing. So why would this fundamental principle of physiology not be accessible to exercise? Of course it is. And actually, if we're kind of sort of thinking about, you know, how those amazing changes in those historical clinical photos came in Katarina Schroth's and Crystal Leonard Schroth's clinic and textbook, this is what we were looking at. We were looking at high volume, high dosage of corrective forces creating growth modulation and tissue changes. So when we are in that space where we're unsure, yes, there's a safety component, and that's fine. But at some point, we're also on the other end of that missing the opportunity to maximize that force, creating that and participating in that growth modulation physiology. And what, again, this algorithm affords you is maybe taking that next step into accessing higher dosage of growth modulation. I hope that helped answer that. It was a great question.
And to answer the second part, can the patient realize these exercises at home? Absolutely. The goal of our program is to make our patients independent and teach them, and giving them a particular dosage of how much and how little and which exercise is ideal, how many times a week. Absolutely. It is something that is part of the school. I'm going to just kind of answer Sean's question. Yeah, basically, Sean, you got that right. If the lumbar curve and thoracic types, if it's not significant, there is an opportunity for us to overcorrect regardless of the curve type, unless it's a thoracolumbar or lumbar curve that is degenerative. So thank you. There was somebody else. Do you want
if I can also add something to this question by Sean, what I have to say is there is an extra criteria, not only the lumbar, because we have not to forget about the S type in our classification. So sometimes the lumbar might not be very significant, but you can still decide not to overcorrect if the proximal thoracic curve is significant. So the idea is to make an analysis of all the structural curves that you have. But basically, when you have a clear major curve, you can overcorrect. However, I don't know if you are familiar with any other schools or classifications. I have to say, in all types, you can decide to overcorrect 3C, 4C, and non-3, non-4. But you overcorrect in 3C plus and non-3, non-4 plus only the thoracic. In 4C plus and STLSL plus, you overcorrect only the lumbar and thoracolumbar. But keep in mind that the only curve type that you can do overcorrection in many exercises is only the 3C plus, because it depends on the characteristics of the curve type that you treat. So 4C plus, non-3, non-4 plus, and SLSTL plus, they do only selective overcorrection, which means they overcorrect only in the overcorrective exercises, because in these types, if you do overcorrection in every exercise, you are in danger of creating compensations, and we don't really want to do that. Sorry, Chintan, you can go.
No, that's, I didn't know how much detail, because there's so many other questions, and I could explain that to Sean later too, but thank you. I think that helped clarify for a lot of other people too. Melinda's question is it possible for a curve to change from one curve type to another if their curve improves or the pelvis becomes balanced? Go ahead.
Yeah. Look, this is something that for those that they come to our education, you will get this knowledge from the very beginning, that a care type can change many times, either as a good or as a bad result. And the role of the therapist is to be there and identify if there is a care type change, and then you have to change your strategy. I can tell you from my own experience, also my previous educations, that I found there to be many significant gaps. Because when you have a care type change, and you see, for example, that the pelvis is not shifted anymore, but is more balanced, you cannot, let's say, destroy the plan that you had so far with the patient. So if you come to our education, you will understand how we manage effectively without creating a lot of changes to the treatment of the patient. And this is important for the therapist, also for the patient when you are in this difficult decision to decide. But yes, you can have a care type change many times. And obviously, for the other question that was already answered by my colleagues here about the de novo scoliosis, yes, of course, we can treat de novo scoliosis, but we don't do overcorrection, obviously, in these cases. We treat them in a more specific way. I think we have to go to the next part of our presentations, and maybe we have, please feel free to send also your questions, and we have time enough to discuss them also later on in the next part. Okay, so
I think I'm jumping into that next section, Nikos.
Yeah.
But before we do that, I just wanted to make one very important point regarding adult de novo degenerative scoliosis. For everybody who is novice to this scoliosis-specific physical therapy, please keep in mind that that is not the same disease process as idiopathic. It has its own progression risks. It is not the same as an adult who had a teenage scoliosis and that teenager is now aging. It is much more rapid in its progression. And it's very important that if you're treating that de novo degenerative patient population, that you have a very clear foundation in the surgical parameters for successful outcome. Because far too often our field in physical therapy participates in kicking that can down the road, so to speak. And when the non-operative treatment is no longer a viable option, they sometimes have missed the window of optimal surgical management because they spent a decade pursuing something without a very knowledgeable, structured following and assessment, and finally reaching the point where we are stepping in our field, participating in the multidiscipline, evidence-based, patient-shared decision-making, helping them to understand that there are just simply some conditions that might not be able to mechanically be held by non-operative means. And should that person personally choose to, then fine, they've had the education and the knowledge of the risks and the benefits, the strengths and the limitations. But for us as a field to be completely saying no surgery ever, no surgery, we play a role in some of our patients missing the window of optimal surgical management for a condition that has a very rapid progression rate and very different research than aging idiopathic. So soapbox number 200 on our, I see one more question. Is the PSSE-Schroth method more relevant for adolescents, or can these principles be applied to adults? Absolutely. I'm a huge, my tagline, if anybody follows anything at all that I say on the rare instances that I post, my statement is you will find scoliosis across all the ages, and you will find scoliosis in all your physical therapy settings. There is hardly imaginable a setting that you're not going to come across it. There is, however, you're not wrong in identifying that there is a gap Because for years, what happened is if you did not require surgery by the time you were done skeletally growing, it's kind of in pediatrics, especially in the United States, bye, have a nice life. You didn't need surgery, see you later. And unfortunately, we didn't have a well-documented natural history across the decades until they popped back up again. And now there is a reason why menopausal women are our second largest patient population in our clinics, is because that significant change in biomechanics, in neurochemistry, in physiological biochemistry, significantly changes, and nobody was following. And now they're symptomatic and problematic. And while there might be variations in other countries, here in the United States, if you're an adult with back pain and a history of adolescent idiopathic scoliosis, odds are the average local adult spine orthopedic is going to address that person in the same way they would someone with a disc or a low back pain with a straight spine. Your pharmaceutical management, your general PT management, and the idea that scoliosis might change the plan doesn't take place. So it's not a surprise in at least the United States, where the adult spinal deformity literature shows an absolute failure of general typical orthopedic PT. I mean, I'm not exactly surprised, right? We know that a spine with scoliosis is not a regular spine that just is out of alignment three-dimensionally. It actually has structural changes. So it doesn't have the same geometry. It doesn't have the same biomechanics. So how and why do we think if we're applying typical spine exercises, would we be getting the same biomechanical response? Of course not. So therein lies the necessity for, regardless of your setting, really coming to understand some of the basic principles of three-dimensional scoliosis. Shall we jump into our section?
But okay. I think I would like to make a comment for adult scoliosis. What you have to understand, guys, is adult scoliosis is divided into different categories. If you have a young adult, of course, you can apply the concepts of overcorrection like what you do in adolescence without any problems. And I can tell you that in young adults, usually you have very significant improvements because they don't have degeneration, they still have good flexibility, they don't have a risk of rapid progression because there is no growth anymore for them. So yes, you can apply. But the adult, if your question was about the adult degenerative scoliosis, that's another story. And obviously, you don't overcorrect. The last question, Marissa, I'm sure is for you. You would like to answer this for infantile scoliosis. So go on, give a short answer to this. Can we work with infantile scoliosis? What do you think?
Okay, so this is gonna make me pull up the story. So I'm gonna ask for a little grace in the story. So in 2009, when I sat in the first BSPTS course, and Dr. Manuel Rigo, who is just an amazing teacher and our mentor, and always so incredibly grateful for his foundation globally and still continuing. He began with the curriculum that said, this cannot be applied to patients under the age of 10. And by the way, that philosophy, and I say philosophy because it's not necessarily theoretically accurate, at least I don't think so, was kind of held across a lot of PSSE schools. And while I sat in that first class, I think all of my colleagues were from your typical ortho adult outpatient, or even kids, still ortho outpatient. Chintan and I came to this from a pediatric neurodevelopment background. And as I began to understand exactly what Schroth was and is, all of PSSEs, is that it's a three-dimensional corrective motion, right? We're teaching our patients a individualized person and curve specific three-dimensional corrective motion, right? Great. And what do we know about motor learning and control? Of course, you can teach complex three-dimensional movements to children. There's an entire field of pediatric PTs who not only teach children movement. We teach children with complex comorbidities in neurological who don't have full access to cognition or language or symmetrical neuromuscular control. So that area of physical therapy is quite skilled at adapting and modifying how we teach motion to children. And I raised my hand to Dr. Rigo, and I said, just while I'm here brand new, I don't remember much about scoliosis except from school and my doctoral program. I think I disagree about the age limit. And I explained this rationale, and he very graciously tilted his head and said, I see we're going to be having conversations for quite some time. And Chintan and I were very fortunate enough to be one of the early teams that took this three-dimensional exercise motor corrective movement and began to apply it and organically kind of blend it with what we know about age and neurodevelopment modified teaching, facilitation, positions, bringing in parents more specifically, creating that customized plan of care. And again, we did this due to the early years, the absolute absence of research. We did this with full transparency, patients and parents and surgeons who were supervising and orthotists who were participating in the three-dimensional bracing. And we were fortunate enough to do some of the very early applications to juvenile and early onset. I think our youngest so far to date has been 3 years old. And we've moved on to apply, even if we're not doing a full scoliosis specific motion, we certainly are now clinically using that three-dimensional principle and its algorithms across all of our patient care, including infant. Okay, if you'll allow me to step into.
I'm sure that you agree with Marissa. I don't know if you have any comment on that, but I know you have worked together for many years.
My only comment is it doesn't stop with the younger ones. You know, my soapbox is in the neuromuscular cases as well. And I think that is an absolutely underserved population. So I think our scoliosis specific PSSE-Schroth method can help a wide variety of patients that we service. And like Marissa said, we encounter scoliosis in every single setting. You know, that's why I like our basic course. I think it gives that fundamental knowledge that at least when you go into treating the next week, you are thinking about the patient's spine, you know, whether it's in skilled nursing, whether it's in outpatient, whether it's in the school district, early intervention. I mean, just in the last month, 2 of my colleagues have reached out to me and said, I have this complex neuro case. You know, one was 7, 8 years old and another was less than 2. This is the kind of impact that we can absolutely have. And if more and more physical therapists would have a better understanding of what scoliosis is and what are the do's and the don'ts, I think we can genuinely make a difference in how we treat our patients. Sorry, soapbox number 201.
We have a lot. It's very true. Very true. Okay, so thank you, Nikos, for that very gracious sharing of your algorithm. One of the factors, you know, Chintan and I have been involved with SOSORT and the Scoliosis Research Society, and it's been a pleasure to watch you as a colleague grow in your research and your practice, and over the years share that clinical rationale and dialogue. And so often, you know, in a lot of professional fields, there is a tendency for this intellectual property kind of sort of holding it closer to your chest. And we're just so grateful that in your graciousness, you're really sharing this globally, helping Therapists who are either new or well established in multiple schools, just continue to expand our clinical rationale so that we can step into that evidence-based practice. So thank you. So let's talk about that educational plan. Okay, there we go. So it begins with a 9 days. That does cross 2 classes, the basic and level 1, but that's your entry into applying the method to the range of scoliosis. The level 2 later on, again, with no particular time frame limitations, ends in that final certification. We're highlighting that growth, that modernization of the theoretical clinical rationale in the education, giving our participants clinical assessment skills and tools so that they can make an accurate prognosis, provide that patient with, again, evidence-based information for that shared creation of a plan of care, understanding the growing range of radiological measurements, not just a Cobb angle, and better understanding as the research is emerging in things like growth modulation. What are the pathomechanisms of progression? The unique patient evaluation form is a great foundation. It's a great place for us to begin all on the same level. The taxonomy, what are the data points that we should all be really looking at? Of course, it's flexible, and that's what we love about a lot of our scoliosis colleagues, is that as we expand our research, it's flexible and open for additions. The basic course, ours is 3 days. It is online. That foundational clinical rationale education, epidemiology, etiopathogenesis, again, giving you that clear foundation for prognosis of kyphosis and/or scoliosis. Understanding what the current scientific data and treatment. This has been an area that, again, we cannot express enough how grateful Chintan and I are to join this amazing international group of instructors who we have been navigating Scoliosis Research Society and SOSORT for over a decade of high-level clinical performance and understanding. The clinical evaluation tools, fundamentals, radiological evaluation, we really do need that in the basics. Physical therapy across the globe still has quite a variation in its fundamental educational structures. Some programs have no introduction to radiological management or measurements. So it's important to equalize that foundation globally. The unique aspect of Nikos's PSSE-Schroth curve type classification and that important algorithm. The level 1 course is 6 days, 3-dimensional principles, again, unique to the PSSE-Schroth and the algorithm. I love that explicit algorithm that just makes that clinical rationale process just a little easier. Practical education on in real time with each other. Of course, it has a written exam. You're not going to have this level of advanced clinical education without an exam. And that certification starts your journey. And again, it is a prerequisite for attending level 2, but there's no limitations in your ability to step forth and begin treating scoliosis and kyphosis in your settings. Level 2 courses, again, another 6 days. This one expands, advancing the exercises for scoliosis and kyphosis, practicing on real patients under skilled instructors. Case-based deep analysis of the treatment decision process, the practical approach, expanding and modifying what we know of scoliosis cases to begin to touch on congenital, neuromuscular, syndromic, adult, degenerative, and even postoperative. This is the course level that we begin to also talk about bracing. It's a critical component for our adolescent idiopathic scoliosis patients that we, again, have the knowledge and the skills to step into the multidiscipline team for the success of our patients and their outcomes. We need to know, is this a good brace? Is it not a good brace? If it's not, what are the criteria and the pieces of information that we're going to take back to that team and help that team to modify or address those limitations so that we can maximize that brace and its positive outcomes for growth modulation? Because everybody needs to understand growth modulation can also occur in the opposite direction. So a bad brace worn really well can actually drive and increase your curves. Sorry again, of course, practical exams. And of course, that final certification. And we're glad to welcome the master's course, which at this point, I think is just a whole bunch of us who love to hang around for an extra 4 days and really dive into the weeds of the deep clinical thought process, practicing, diving into some of the more subtle differences between motor performance, say, for example, or the variations that we really do see in our clinic, especially when you're practicing for a length of time and you're becoming more comfortable with the knowledge and your own skills. You can really start to grow your professional development. We talk more in depth about that blending or seeing and identifying the strengths and limitations for all of our schools, including our own. You know, this is a global approach as the research continues to grow. Surgical options for scoliosis and kyphosis, not just spinal fusion, but the non-fusion techniques. And of course, for those that are, up to date with the research, we now know we have hybrids. Look at how rapid that research is changing. I remember when VBT was brand new, and it's the hot new widget, and now we have hybrids. Now, anterior fusion was for quite some time put on thing, and now there's a resurgence in some countries of anterior fusion. How do we, as skilled, advanced physical therapists, step into, once again, these multidisciplinary teams? Understanding more about research methodology, modifying the exercises to help our patients live real lives in the community with Pilates, yoga, TRX. What am I doing at home? What am I doing at work? I do not have 30 minutes. Can you give me something that's going to consistently give me 5 minutes of this in my work setting? Again, Chintan and I couldn't be any happier to join this amazing global team of instructors. These are our US courses that are currently open for registration. Our basic is online, end of March the 28th. Our level 1 is in person in our facility in Totowa, New Jersey, May 20th to the 25th. We're very excited to be closing some details on West Coast and Southeast courses, and very excited to announce the opening of some South American courses that hopefully will be coming. For those of you that might be more already established in scoliosis-specific exercise, stay connected with us. Join us for the expansion of scoliosis in its application for comorbidities or dual diagnosis, things like pelvic floor, motor learning and control, hypermobility syndrome, and anxiety. And we can't thank you enough for taking the time for your professional development, whether it's new or already established for years in the world of scoliosis. Thank you for joining us on a Sunday evening here on the East Coast. For those that are globally somewhere else, whatever your days and times are, I'm not doing math at this time. And I think if we have a couple of questions or chats, we have a few more minutes.
Before that, there is a part also to be presented, and then we'll go to the questions and answers. So we already have one question on the chat, but I would suggest to go with the last part of the presentation with some of the results from our school, and then we can have a discussion. So feel free to send your questions, and we'll come back in a few minutes.
And if we don't get to the questions live, we certainly will take them in, and we will respond after the webinar.
Yeah, definitely. So let's have a very quick look on the principles of correction for our school. So we have the 3B autocorrection, the first principle of correction, which includes the self-elongation, the pelvic corrections, the symmetric or asymmetric sagittal straightening, frontal plane correction. So we apply all the corrections to the patients, corrective or rotational breathing to expand the collapsed areas, and muscle activation to maintain the expansion, to increase the activation. We use some specific techniques like the shoulder countertraction or thoracic countertraction, and we apply also a lot of different mobilizations. And then we have the stabilization. So the main idea of what we do is, first, we need to bring the patient into the ideal 3D correction. Of course, it's self-correction, so active correction by the patient. We do the corrective breathing to expand the collapsed areas, and we activate in correction. Then when we finish the exercise, we need to stabilize the correction for the patient and to implement into the daily life activities. So here you see a patient with left thoracic, right thoracolumbar scoliosis. You can see the asymmetries on the patient, on the pelvis, on the shoulders. You can see the rotation. And during the exercises, you have to see everything to be well aligned. This is what we do during the exercises, but then of course we need to implement the correction into the daily life activities because we aim to reduce the asymmetric loading of the patient's spine, not only during the exercise, but also during the daily life, and to prevent progression or to improve scoliosis. So we train our patients how to sit, how to stand, how to sleep, and obviously we follow our classification rules for this education of the patient. Here you see a patient that was classified as 3C+, very significant thoracic scoliosis, no lumbar curve, imbalanced pelvis to the thoracic concavity. And here you can see this patient doing an overcorrective exercise on the left. This is the mermaid on the floor exercise, and you will see how we use our hands to guide the patient into correction. And then you will see my colleague there to guide the corrective breathing for the patient and applying also some mobilizations for the patient. Here is how we expand the thoracic concavity, and for those that you are more familiar, the ventral flat zone area. And we do also some specific mobilizations for the patient. And here you can see, so this is an overcorrective exercise. And here you see the same patient in a so-called normal exercise for us, that we try to put everything in a perfect balance in this 3C+ patient. You see how well she is expanded on the concavities, how well is the hump corrected, and the patient is practicing also the shoulder countertraction technique. Going now to this slide, I can say that we have more and more recognition by the scientific societies, the social, the SRS, also the pediatric orthopedic societies of America, and all of them, they admit that the PSSE can be the first step in scoliosis treatment to avoid progression and possibly also bracing. And there is evidence that PSSE are superior to non-specific or general or no exercises, and can prevent the risk of progression. And we also know that brace plus scoliosis-specific exercises is better than brace without exercises. Here, there are some studies coming from our school because we have also to present our data, our evidence behind this PSSE-Schroth school. And here is a study that we had patients below 25 degrees, and we had a control group and a group of PSSE-Schroth exercises using very strict inclusion criteria, 15 to 25 degrees at the peak of growth, more than 5 degrees of rotation, less than 1 year post-Menards, and we got a success rate of 87%. So success rate means no progression. We had almost 25% of them getting more than 5 degrees of improvement, while the control group was only 26%. And you can see also the difference on the brace prescription. We had almost 10% for our group when the control was 67%. And we improved also aesthetics and quality of life, proving that PSSE-Schroth exercises can be effective to reduce the risk of progression. And here is another study that we combined brace and scoliosis-specific exercises with PSSE-Schroth method using the SRS criteria, 25 to 40 degrees less than 0 to 2. And we got a success rate of 88.5%, one of the highest in the published literature so far. And only 6% of our group overpassed 40 degrees. So it means when we have an early detection with a proper treatment with brace and scoliosis-specific exercises, we can effectively treat scoliosis at the riskiest period or during the peak of growth. And I also have to say that our classification is implemented also in the brace design. And here I will briefly show you some of the results of our cases. This is a patient with a mild scoliosis of 20 degrees treated only with exercises. We got a reduction of the curve from 20 to 7 and also clinical improvement. Similar to this case, from 23, we went down to 9 degrees. So in these cases, the main aim is always to stop progression, to avoid or delay bracing. This was a double scoliosis, 18 and 20 degrees, right thoracic, left lumbar, and we brought it down to 17 and 12 without bracing. All these cases are only with PSSE-Schroth exercises. You see another patient with a double curve, 18, thoracic, 22, lumbar, brought down to 13 and 14, and no brace was needed in this case. Here we had the left thoracolumbar of 25 degrees with quite significant, as you can see, rotation, trunk rotation, also vertebra rotation. And you can see the result that we got for this patient, bringing her scoliosis down to 10 degrees. And you can see also the very significant clinical improvement, also in the trunk rotation, but also on this side of the slide, you can see the vertebra rotation improvement. Now, when we have patients above 25 degrees, but at the later growth stage, we can still work with them with only with exercises, without bracing, like in this case with 31 and 34 degrees, that she was brought down to 22 and 20. And again, you can see the significant improvement on her body balance, on the shoulders, on the pelvis, also the trunk rotation, because aesthetics is very, very important for these patients. Another case, reserved for 30 degrees. We work only with exercises. We go down to 13, look at the clinical improvement, and look at also the improvement of the vertebra rotation after treatment. Now, adult scoliosis. Of course, no brace indication for adults. So this was a young adult patient with 41 degrees. And you can see the very significant harm before treatment. She went down to 36, and she also had a very nice clinical improvement. Another case with 53 degrees, she was recommended for an operation, young adult, 24 years old, with significant pain on the right thoracic area. And we managed well with her. We improved the curve from 53 to 46. Again, you can see the radiological improvement of the vertebra rotation and also the clinical improvement of this patient. This is an extraordinary case. We don't have this result every day, to be honest, but we got this amazing result of this lady that was almost 40 degrees when she came to us with significant pain, 73 degrees, progressive scoliosis. 15 years ago, she was 58 degrees. So she had a steady progression by time, and we managed to correct this scoliosis from 73 to 55 degrees, improving the pain and also avoiding the operation for this patient. Obviously, when we have brace indication during growth, we have to work together with brace and scoliosis-specific exercises. And as I mentioned before, the brace design is according to our classification. You can see this patient with 32 and 33 degrees went down to 16 and 8 degrees. This is out of brace X-ray. From 30 and 36, we went down to 16 and 23 degrees. This is the in-brace X-ray. We got a very nice reduction of the curve in the brace. The patient was compliant with the brace and exercise treatment, and 2 years later, we had a very, very significant improvement for her. This is a patient living outside of Greece with 31 and 41 degrees from Albania with a very rapid progression for her. She was recommended for an operation in her country. She came to our clinic. This was the in-brace X-ray, and this is the result for her 2.5 years later. From 41, we are down to 16 degrees, and you can see also the improvement on the patient body. Another case, from 45 degrees initial, we went down to 34, and you can see the improvement on the patient's body, pelvic symmetry, and also the trunk rotation for her. Another one, so even more severe scoliosis can be effectively treated by brace and scoliosis-specific exercises. From 48 degrees, we went down to 39, having a very nice treatment result for these patients, or even more severe sometimes. This case was with 67 degrees of scoliosis, was treated with brace and PSSE-Schroth exercises in our clinic, and we got a very nice reduction of the curve, improving also his body balance. Another case, 65 degrees, went down to 47. And I left for the last part some cases that, for some people, they say neuromuscular scoliosis, no evidence for brace. Of course, there is no evidence for brace, but always there are some good responders. So these patients with some walking ability, with support, with cerebral palsy, she was recommended for an operation with 45 degrees. Look at the in-brace correction for her and look at the result 1 year later. And this is, again, an extraordinary case, very recent treatment result. Of course, we're still working with this boy. He's 11 years old with a spine schwannoma with 74 degrees of scoliosis. Look at the in-brace X-ray. He goes down to 26 in the brace, and the result that we got 1 year later was 25 degrees less on his scoliosis. So thank you for your attention, and I think now is the time to have your questions to be answered, so feel free to comment, ask any question you want to ask me, Marissa, or Chintan.
And again, we thank you all for joining us.
Spending your Sunday with us.
I hope this gave you an opportunity to ask some of your questions, learn more about the curriculum that's available and the courses that are pending.
So some of you asked before about the recording. We gave you an answer, but just to announce to all of you that very soon, maybe tomorrow or day after, this webinar is already recorded, so it will be uploaded on our official website on www.schrothpsse.com. So if you click to the webinar section, you will find the webinar and you can attend it at a later stage on your own convenience. There is a question, Chintan or Marissa, I think you have to give the answer to the question. If we have more courses in New York or New Jersey,
we will be expanding in the Northeast, and as I said, the Southeast as well. So if you begin the basic online, the Southeast offices courses coming up might be an option for you as well. But we will at some point also have more in the Northeast. You're very welcome, Janice and Andrea and Christine. Janice, thank you for that question. We actually were talking about taking that 6-day level 1 and dividing it into 2-3 days. In busy work, it's sometimes hard to take 6 days off. We were actually taking that into consideration. So again, taking the basics will give you the prerequisite, and we will be looking forward to maybe providing that modification in the near future. You're very welcome, Stephanie.
There is a question if we can do short courses. I don't know what exactly you mean by short courses. Our plan is to do some kind of webinars like them, but the structure of our educational plan was presented by Marissa before. I don't know if we can, let's say in the future, try to split the 6 days in 3 and 3. I don't know if this is what you mean, but the protocol is quite fixed, so we don't give a course of 1 or 2 days. But if you speak about pelvic floor or hypermobility or neuromuscular scoliosis, yes, maybe we can have some shorter courses in the future, if this is the question, because I don't know if I got the meaning right. Yeah, I got the answer by Jessica. that a shorter duration course, breaking level 1 in 2 courses, would be fantastic. So this is something that we discuss in our team of instructors, and I can tell you that we have already tried this in 1-2 countries. It worked well, but it depends also on the availability of our instructors based on the country. So I cannot give you, or we cannot give you a definite answer now, but it's something that is under consideration.
Thank you, Susan, for the question about the connection with torticollis. In my pediatric development days, infant torticollis was my jam, so to speak. Karen Carmel Ross trained early plagioccephaly. The fascinating correlation is that there's a 30 to 33% correlation between congenital muscular torticollis in infants and idiopathic scoliosis. It might not actually be a lateralization that evolves over time. It's a much more complex multifactorial genetic condition, potentially connective tissue disorders that just are not originally correlated. We're really unpacking so much of the condition and its etiology and its genetics and its dual diagnoses and so forth. So Susan, definitely email me, reach out. We'll be more than happy to kind of sort of collaborate and give you some fundamental scoliosis information to put into your torticollis trainings. We'd be happy. It'd be nice to bring my babies back.
I'm gonna try to see if I can put up that one slide with Marissa and my email. And
Wow.
Nikos, I know you have the ability to put things in the chat. There you go. He already did it.
Mahmoud, thank you. You're very welcome.
I'm gonna just put our emails.
There is also a question by Ainur. What is the treatment protocol, dosage, duration, hours? Hi, Ainur. First of all, we hope to see you also next month in Sosok. Look, you always have to do an individualized assessment. So it's not a fixed protocol that you have to provide to your patient, because if you have a patient at a high risk of progression, you might need to work more intensively with them, so 5 or 6 days per week, almost every day. But if you have a patient with a lower potential to progress, then you probably need to do less. So our advice is always individualize your assessment, and based on these clinical, radiological, and prognostic criteria, you have to choose the proper treatment, avoiding under or over treatment for the patient.
Melinda, I'm going to field Melinda's question really quickly. That's very interesting about retained primitive reflexes in idiopathic scoliosis patient. Again, this is an area that is just blossoming and unpacking. There is emerging proprioceptive, neurological, visual system impacts, whether it is compensatorily evolved or whether it is a part of the underlying etiology is yet to be determined and so forth. But yes, those of us that have been working in the field for quite some time recognize this multi-system involvement. So you would not be erroneous in identifying that. Good.
A lot of our patients also work with a lot of issues with vestibular issues and training. So there is definitely, like Marissa said, we don't know if it's part of the etiology or is it part of compensations. But as you get into treating scoliosis, you end up really fine-tuning. And I think that master's course can really help us hone in. I think first we have to get much better with understanding scoliosis, much better with identifying and classifying, and we can treat our more and more patients in every setting before we have to fine-tune some of those more difficult cases.
There is also an interesting question by Kathy about treating primary upper thoracic curves. So yes, of course, we have some specific corrections that we apply. Obviously, there was not time enough to be analyzed in this 1.5-hour webinar, but we spent, I can tell you, 1 hour or 1.5 hours, one of the days of our level 1 course that we analyze which corrections you have to apply every time that you have a structural proximal thoracic scoliosis. So yes, we take it into account and we spend a lot of time to analyze how you correct them.
And remember, this was just an hour and a half of what is, you know, a total of 9-day course. So
Right.
if you just have to understand, there is so much information. Scoliosis is not a straightforward, simple diagnosis. It is very complex, and I think the tools that are developed and distributed in this course really will help you. Like as soon as you're done with your level 1, you'll be able to effectively treat your patients, which is great. So some of the things that you're asking,
or the settings.
yes, regardless of the settings.
I think we are done with the questions. So you
so.
have the emails of Marissa and Chintan if you want to get connected with them. You also have our official website and our official email if you want to get connected with the school. And we hope to see you soon in a conference, in our courses, wherever. We hope to be in contact with you, and we hope that you enjoyed this webinar. And thanks again for one more time for your time. And I have now to say thank you also to my great colleagues, Marissa and Chintan, for your lectures, for being here with us, for making this webinar to be possible.
It's been a pleasure as always.
Thank you for bringing this to us and obviously the US. I think it's, in my opinion, it's like, I wish clinically I had this right from the get-go. We problem solved a lot of things along the way, but this method does make it easier for novice therapists to execute and utilize the scoliosis specific training for their patients. So thank you for putting in the hard work and, stepping into this. I know how hard it is to write up a whole program like this. So thank you for all your efforts and all the research and all of the outreach, everything that you do. So we appreciate you, Nikos.
Thanks a lot.
So grow over the years.
Yeah.
All right.
So thanks to everyone. We hope you enjoyed it.
Night.
You'll have the recording uploaded very soon, and we'll be in touch with all of you.
Have a great night, everyone.
Good night to everyone. Have a good Sunday. Bye-bye.